who is in the Center for Transplant, as our guest speaker talking about cystic lesions of the pancreas. Dr. Almeda is a native of Del Rio, went to St. Mary's University and then went to this medical school. He's a graduate of this medical school as well as this general surgery residency, and then did his transplant fellowship at USC, and then came back and joined us here on the faculty. Jose, it's a pleasure to have you this morning.
Thanks, sir. Can you guys hear me okay? So, in this setting, we've talked about pancreatic cancer a few times. And the deal with that setting is that by the time we get to the end, I want to talk to you guys about cystic neoplasms, but we really usually don't have any time. And so, Dr. Stewart recommended this topic as sort of a small lecture in and of itself, so it's really only about half an hour. And today I've invited Dr. Patel. He's the director of our therapeutic endoscopy lab, and the reason I have is because A, maybe you guys don't all know who he is, B, when we're dealing with the cystic neoplasms, it's a lot of back and forth because the bottom take-home point here is these things look a lot alike, especially on a CAT scan. We're going to talk about 4, and on a CAT scan they all look the same. So when it comes to pancreatic cancer, I can look at a CT and kind of come up with a plan. But when it comes to these masses, they're a little bit different. And you know, Dr. Patel will tell you that he sees about 5 to 6 of these things in clinic all the time, and he has to determine whether they're benign or they're malignant. And so we'll just go ahead and start. Pancreatic cancer we've talked about. We can do crazy revascularizations. Well, the thing with cystic neoplasm, though, is you rarely ever need this kind of arterial reconstruction, so it doesn't get this crazy. And so you guys may think, well, why do we have to focus so much on cystic neoplasms of the pancreas, or why is it a sort of a lecture in and of itself? Don't you just cut these things out? Well, sometimes you do, and sometimes you can't. So this is a nice lady that Dr. Patel and I took care of recently, and we actually took her to the operating room. Let's see if this pointer works. Yeah. So here you can see the body of the pancreas, cystic lesion, and this little tiny nodule right there is what's concerning. So when you start talking about cystic lesions, is this important or is this not? Is this something that's bad or is this not? Is this something that can turn into a cancer? One of the things that we'll go through is size, and the other thing is these small nodules. We don't know if that's debris or not. So that cannot be a nodule, that can just be debris. So we've talked about scanning this lady upside down, but I don't think she would tolerate that very well. And does anyone notice anything on this CAT scan that's probably not normal? And so, without dragging it on too long, these are varices. Varices, varices, varices. And there's more. I didn't put the whole film on, but what we're seeing a lot is the patients from South Texas over and over. We have a lot of patients that are coming up to us from the Rio Grande Valley. And what you read in the newspaper is true. Fatty liver, NASH, we're transplanting a ton of them. And they're popping up in the OR with no biochemical indications of portal hypertension except maybe some thrombocytopenia. And so this lady, I stuck a scope in her and she was completely cirrhotic. So bailed, saw those varices. I was a little worried about it, which is why we started off laparoscopically. And so we bailed. I don't know, Brett might have been there with us for this one. And so that's fine now, but now Gloria is in clinic and she wants to know what's going to happen to this thing. Should we cut it out? Well, we can't. So should I get chemotherapy? Well, no. Is this going to turn into cancer? That's the question. And so I have nothing really to offer her from my standpoint, but she really wants some risk stratification. And that's what we're talking about today with 4 simple lesions that we'll talk about. We'll go through the types. I really want Dr. Patel to tell you about the endoscopic and the diagnostic challenges that they do because he sees so many of these in clinic and he has to determine which of these are bad, which of these are okay, which of these should be cut out, which of these are simple cyst, what's the treatment, and then I just have one slide I want to share with you from Stanford of some new treatments that we have. When you think about pancreatic lesions, there can be congenital cysts or they can be acquired cysts. We're not going to talk about those. Acquired cysts are pseudocysts. I think this can be a lecture in and of itself, but we won't talk about today. That's can be an exhausting topic. all we're focused on today are the things that might be on your app site, the things that may face a lot of you guys with incidental CT scans when you find them. And they're the primary cystic neoplasms, and they're basically four. You have serous, you have mucinous, and you have IPMN and pseudopapillary tumor that you'll see on the bottom. And Dr. Patel will tell you why it's important to differentiate whether they're mucinous versus not. We'll talk about those four that I just said, and we'll start off with serous. So I'm going to give you two slides, one on serous, one on mucinous, and then let Dr. Patel jump in to tell you how he figures out the difference between the two and their characteristics that may be on your guys' app site or your guys' board test. And I did have one of these as an oral board question, two of them actually. So the serous cystadenomas. One of the things that, again, CAT scan, it looks like a cyst. They all look like a cyst. I'll show you a couple, but they all look like a cyst. Serous cystadenomas, they have simple cuboidal lining that you can see down here. These are very cystic, and believe it or not, they have this central scar that's right here. And you're not going to see this on a CAT scan very well. All you're going to see is this is all a cyst. This is homogenized, but it's really just a cyst. It's more common in females, but so is mucinous. But more common in females. It can be associated with other diseases, and they're slow growing. The thing about these is they're almost never malignant. So if this was the ladies with the portal hypertension before, and if I knew for a fact it was a serous cystadenoma, I could tell her to go relax, and that she'll be just fine. She'll probably have more problems with her fatty liver disease than this. But it's differentiating the two that we need our GI colleagues to help us with. Because again, on the CAT scan, it looks like this. So Gloria actually has a mucinous tumor, and this is what Gloria does have. It's different from the serous cyst, again, because it has mucin, but it also has histologic heterogeneity with malignant potential. So these, along the spectrum, more so than serous, can turn into a cancer. The key thing that sometimes I even underestimate, I think the residents have heard us talk a lot about if it looks like a duck and it walks like a duck and it acts like a duck, it's a duck, no matter how many times you stick a needle in it. It comes from some of these things, because if they're symptomatic, in all the studies, and a couple of studies that we'll show you, in all the studies, that's a red flag. So true, if they have biliary obstruction, if they have pain, if they got to you, not because of an incidental CAT scan on a trauma patient, but because of symptoms, that's another red flag to think about. Again, more frequent in women, just like serous cystadenomas were, but usually within 40 to 60 years of age. So those are serous cystadenomas, that's mucinous cystadenomas. Now, how do we figure out the two? Because for Gloria, we didn't know if she had a cystic lesion, a cystadenoma, or a mucinous cystadenoma. And so for that, we'll let Dr. Patel tell you how he figures all this out.
Thanks, Jose. Well, first of all, it's a pleasure to be here. Thank you for the invitation. And all these ducks look the same. So, some series state that 5 to 10% of all CT and MRs done in this country will show a cyst in the pancreas. And then in this era, as we all know, where everybody in the ER gets a CT scan or an MR as part of the triage process, that brings up a lot of referrals for you guys and for us in terms of determining what these cysts are and what we do about them. So, this is becoming a bigger and bigger clinical dilemma as time goes on. And so this is the algorithm that we like to use. We perhaps, being gatekeepers, might see this a little more often than you guys do. But not all of these ducts need to be operated on. And a lot of these really can be watched. So as Jose mentioned, we've got benign cysts that can be clumped into congenital cysts, acquired cysts, and then more importantly is in the center. We want to try to tease out the cystic neoplasms of the pancreas, and they can be broken down into two major groups, depending on what their contents are, either mucinous cystic lesions or non-mucinous cystic lesions. The non-mucinous cystic lesions tend to be less worrisome. Jose already mentioned serous cystadenomas, which are quite common. They're microcystic lesions, and I'll show you some examples of what they look like sonographically, because by CT or MR, again, all of these cysts look about the same. You'll be really lucky to be able to delineate just based on CT what the cyst is. So A serous cystadenoma you like because they almost never become malignant or don't have any malignant potential. And as Jose mentioned, they can be watched. They rarely will make it to you guys. If they do make it to you guys, then be wary of that. That person does not need to go to the OR. The other is the pseudopapillary tumors of the pancreas. So we've all seen these. These are usually young females. They do have malignant or pre-malignant potential, and these folks tend to be symptomatic. So they do need to be resected, but they're fairly indolent. The more worrisome ones are on the right. We have mucinous cystadenomas, which are pre-malignant, typically occurring in your middle-aged females, 40 to 60. You have, they can convert to mucinous cystadenocarcinoma. And you have IPMN, Intraductal papillary mucinous neoplasms, of a couple of variants, either side branch or main duct disease. And all of these we take pretty seriously. We'll spend the rest of the day talking about, the morning session talking about those. Now, what we like to use as gastroenterologists is endoscopic ultrasound to help us delineate these morphologically. I'll kind of walk you through how we do this and why we do this. Up on the top right-hand side, you see, for those of you who aren't familiar with the procedure, it's a standard endoscopy with an ultrasound probe at the tip of it. And they can come in two formats, either a radial transducer or a linear transducer. And it's wonderful for looking at the pancreas because you can see the anatomical relationship there. Along the posterior wall of the stomach, you can essentially see within a centimeter or so from your transducer the neck, body, tail of the pancreas. As we go around the duodenal sweep, you can actually see the head of the pancreas very nicely with incredible acuity. We can pick up 2 to 5 millimeter lesions anywhere in the pancreas with this kind of resolution. And here's what the echo image would look like. You've got your splenic vein portal confluence, and wrapping around it essentially is, just like you guys see in the OR, your neck, body, tail of the pancreas. And under normal state, the pancreas, under normal sono state, the pancreas has a kind of a salt and pepper appearance. Chronic pancreatitis will look dark and what we call hypoechogenic. Masses will turn up black and spiculated. So they're very easy for us to see sonographically speaking. And this is what they look like in real time. So you can see the pancreatic duct, which measures about 2 millimeters in diameter. So you can see how well this shows up on echo. You can follow the pancreatic duct as it joins the bile duct around the portal confluence towards the head of the pancreas. You can follow it up and to the right, to the body and tail of the gland. And we're doing all of this from the stomach. So a fairly non-invasive way of getting a nice look at the pancreas with fairly high resolution there. Okay. So serous cystadenomas are very easy for us to pick up because unlike all the other ones, they're microcystic lesions, what we call honeycomb type lesions. And you can kind of see right where my hand is that this cyst has lots of small pockets of microcysts. And you can actually see the central scar right in the center of it. So when we see this, this is essentially pathognomonic for a serous cystadenoma. Occasionally we have the ability, or we may FNA this, and if we FNA this, we'll get, as Jose mentioned, cuboidal cells. They'll typically be acellular. We won't get much fluid out of it. If we do get fluid, it'll be serous fluid, serous sanguineous fluid. It won't be mucoid, and we're essentially done. You'll never see these patients. Now, on the other hand, we've got these cysts, and you can see that these look a lot different. You know, again, I mentioned on CT scan you may not be able to delineate this, but here you have what we'll call a macrocystic lesion, a cyst made up of multiple large cysts with septations. If we see this, we can put a needle into that cyst and aspirate fluid. We can do a bedside test on a slide and do what we call the string test. We're all familiar with the string test, just a slightly different setting. And we can determine whether it's mucoid. We can send it off for viscosity to confirm that, or a glycogen stain to confirm that. And now we're in that category of lesions that we're somewhat worried about. At this point, where our differential would be, here we have a mucinous macrocystic lesion. Let's say this is a 60-year-old female, 70-year-old female. What are we thinking at this point? Forget that I've got the answer on the top of the slide, but you know, we would say, well, could this be a side branch IPMN, a main duct IPMN, or a mucinous cystadenoma? Period. That's it. And then it's our job to try to determine which of the three that is, because that'll have some factors on what you guys are going to do about it. All right. I think I'm going to hand it right back to you at this point, Jose.
Thanks, Cindy. So as you can see, we're going more malignant now. We started up with serous, then you got mucin, now you got a symptomatic lesion that has mucin, and it's has more of a malignant potential. And right down that extreme, right down the line, we get into IPMNs. And so these were described in 1982, and if you look at the amount of studies that have been done since then, it's just exponential. And a lot of these studies were done in Japan. And so a couple of those studies I'll just briefly go over. But when you're talking about an IPMN, this was a board question I got, 82-year-old gentleman, IPMN, what do you do? And so the answer was easy, oh, you do a Whipple. But then the second question was a little bit more involved, and it says, well, the guy doesn't want surgery, he wants you to talk about what his risk stratification is. Well, that's not quite as easy. But after this, hopefully, you can be able to answer that question. So once you have a mucinous lesion, the question is, does it come off a duct? So is this a main duct, or is it a branch duct issue, or is it more like a mucinous tumor where it's just sort of hanging out in the periphery somewhere? So main duct versus branch duct, and it has a KRAS mutation on it that Dr. Patel, Sandeep might talk to you about. And a lot of times the medical students, or even some of the residents, sometimes will say, well, what's the difference? They both have mucin in them. Well, that's the key there, is whether or not they come off the duct. You know, we can go back and forth. Here's IPMNs, here's mucinous lesions, which are in the head, which are in the tail. Well, they're both going to have mucin. You know, it's both about the same age discrepancy. I can tell you that even in our practice, IPMNs are many more times found in men. That is true. That is one take-home point that maybe you can take. Again, my board question was an 82-year-old gentleman. Where they're located, I've seen them everywhere, but I guess, you know, you typically think of an IPMN in the head, but they can kind of be anywhere. And once again, it's whether or not it communicates with one of the ducts or not. And sort of that's one of the things that is a hallmark, the difference. So they both have the word mucin in them, but whether or not one of them is coming from the duct, hence the pathology of it. You know, why are IPMNs important? That's why, because there are ABSITE questions about them. And then, you know, the other thing is these patients will be in your clinic, and since they're found in older patients, so sure you can operate on some of them, but a lot of them you can't. And so they really want to know what's going to happen. And so there's even a grading system to be able to talk to them about, which is a little bit difficult to do when your pathology is based on a tiny little 21 gauge needle that's poking holes in this thing. But nonetheless, they all have dysplasia and they all have the risk. And what we see in a lot of these is even when we send the pathology, the frozen specimen of the neck of the pancreas, they'll say, well, we still see dysplastic cells. So you cut a little bit more of a margin towards the spleen. We still see dysplastic cells. You cut a little bit more of a margin. I've always had a discussion with these patients preoperatively saying, if I find that, because we often find that, what do you want me to do? Do you want me to take out your whole pancreas, or do you want me to stop as is? You know, I'm of the personal belief that you can stop as is. I think that these dysplastic cells, and it is talked about, that travel through the duct of the pancreas all the way downstream towards the spleen. And so one of the things is, like I said, you always have to talk to your patients before, because it's possible that you'll find dysplastic cells through that once you start doing your resection. So as you can tell, more of a resection now. We've gone through serous, we've gone through mucinous, now we're talking about IPMNs, more of a malignant potential, but it really is based off what kind of IPMN you have. Do you have a main duct? Do you have a branch duct? Main duct up to 50% malignant potential. Dr. Stewart thinks it's even more probably. Branch duct, anywhere between 2 to 20% 5-year survival. So there's studies of people that really are watching the branch duct lesions. And if it's greater than 3 centimeters period, as you can see, this IPMN here in the head of the pancreas, probably going to be malignant. there are selection criteria. So there are a whole bunch of people that Dr. Patel travels to Japan with and has sushi with, these people that develop what they think or how to manage these IPMNs. You know, Sandeep will be gone for about 2 weeks, and I'm not really sure how much work he gets done versus how much sushi and sake he drinks. But so most recently, the Sendai criteria. So what they're recommending is kind of what we always talk about. If it's a main duct, take it out. If it's a branch duct, look at the size, because size matters. So greater than 3 centimeters. If there's a mural node, which is hard to tell. Remember that first lady with that tiny little thing on the bottom? Well, should I scan her upside down or not? Well, that's difficult to tell. But once again, we're back to what I told you guys a while ago, is that if they're symptomatic, that's a big red flag. Malignancy in IPMN of the pancreas, well, there was 82 patients. Kind of repeats what I told you guys about. But I'll let Dr. Patel talk to you a little bit about this, because he's intimately involved with that study. But this is the branch ducts. So this is a study where they had 82 patients and they watched them, and they wanted to see what would happen to them. Well, out of the 82 patients, long story short, go down to the bottom, 7 of them went to surgery. None had invasive cancer, so more the impetus to watch these lesions. But that's kind of the key characteristic. So how do you know if it's a branch duct? How do you know if it's a main duct? How do you know if there's a mural nodule? How exactly do you figure out the size? Because on a CAT scan, it kind of looks like this big cystic lesion. Well, for that, I'll hand it over to Dr. Patel, because I also want him to tell you a little bit about how he knows if you can watch these lesions. Which are the ones that you feel comfortable watching as a main duct lesion?
Thanks again, Jose. It's an effort to make you guys dizzy. But so, as Jose mentioned, it really when we're talking about IPMN, and again, it can be difficult to discern from a mucinous cystadenoma, but he gave you some great generalizations in terms of man, female, and age. But really what we want to do is be able to determine whether this is a side branch IPMN versus a main duct IPMN, as Jose mentioned. In general, IPMNs have a much different biology from your run-of-the-mill ductal adenocarcinomas. Again, I think that's a pearl, that's a take-home message here, and this is why we're talking about it. Even if you look at post-surgical data and 5-year survival in people who develop cancer in the setting of IPMN, the 5-year survival in that setting is 45 to 50%, as opposed to about 15 to 20% with your typical adenocarcinoma of the pancreas. So when we make this diagnosis, I tell our patients that if you're going to have a tumor in the pancreas, this is the one to get. You know, you get a proliferation of the duct lining or the ductal epithelial cells. They tend to be mucin producing. They can be a few different types of biologies and histologies. They can be of the gastric type. They can be of the intestinal type. But most importantly, you know, these are all precancerous lesions that we feel follow the colon polyp pathway, the KRAS mutation pathway. So it takes a long time, from initial insult to second hit to polyp to dysplasia to carcinoma. So we tell our colon folks that you have 10 years, you know, and that's about what we see in IPMN. Even in main duct IPMN, when you look at the original Japanese natural history studies and data, which is where most of this comes out of, because they've identified this much sooner than we did. This has sort of become vogue in America over the last 5 to 10 years. They'll even tell you that this is a disease of decades. So we can watch this for the most part. Again, we want to be able to determine side branch from main duct, because I do agree with Jose, you know, that of the two, main duct seems to be more worrisome. We do find cancer more often in the main ducts rather than the side branches. And hence, if you have main duct IPMN, you're convinced of it, the algorithm is surgery. It's not so easy, though. You know, as Jose and I will tell you, and Ken will tell you, and Wayne will tell you, all of us who have had to deal with, and Glenn will tell you, is that this poses a difficult conversation with the patient. We'll get into that here in a second. So, again, wow, I guess I should say. EUS helps you tremendously here, EUS and MRCP. Here you have a cartoon on the top which shows a very bulbous ectatic pancreatic duct. So this would be main duct IPMN with some dilated side branches. So you may say this is a combined main duct side branch. And here's what we'll see on ultrasound here on the bottom. Typically, sonographically, you'll be able to see the main duct of the pancreas that looks non-dilated, normal contour, doesn't look thick. And then you see in cross-section what look like just dilated side branches. Here in the middle, you have a combination of dilated side branches, as well as a massively dilated cystic structure, which is the main pancreatic duct. And then to the far right, you just see a continuous duct that's dilated, which would be a main duct, IPMN. If we were to do an ERCP, saying we put a catheter in the pancreatic orifice and we inject contrast, look at the images on fluoro, this is what you would see. On the left side, I'm just going to leave it to the audience. What do we think that is? Side branch, main duct, combination. Can you tell? Yeah, I mean, it's either going to be a main duct or a combination. We don't know. I haven't shown you the entire pancreatic duct, so it's not fair. But here you see the scope. You can see a catheter with a radiopaque marker. We're in the pancreatic duct. We inject contrast, and right away you've got a fairly dilated pancreatic duct that looks a bit tortuous. And I would be very suspicious that this would be a main duct IPMN. Obviously, you can't rule out chronic pancreatitis, which would give you a main duct dilation. But here you don't have a stricture with upstream dilation. So again, one of the clinical dilemmas here is this chronic pancreatitis? Is this main duct IPMN? And that's stuff that we have to sort out. In the middle, a little bit easier and maybe perhaps a little bit more obvious to you guys. You have a normal pancreatic duct in normal contour, and then about midway up, you see a bulbous outpouching of the duct, and that's what a side branch IPMN would look like. And probably the most rare of all variants is here on the right. And we've had a couple of these over the years where you've got a fairly normal pancreatic duct. I'm going to point because every time I touch the computer it advances. And then something happens here and especially here. And this is what we call borderline IPMN. You know, this is somebody we've been watching over the years, has a normal pancreatic duct, and then during the 6-month interval, all of a sudden their pancreatic duct looks completely different. It tends to be out in the tail, and you get degeneration of the duct. And this is what we would call a borderline IPMN, meaning they are starting to make the changes towards dysplasia. We take them for a distal pancreatectomy, and we find high-grade dysplasia. Not overt cancer, but high-grade dysplasia in that portion of the duct. So that's what I would call the engine has sort of turned on. 6 months tends to be a pretty reasonable surveillance time period, and we'll get into that management and some of the management issues here in a little bit. On the top, too, you see the endoscopic images that are pretty classic, and these are fair board questions on what main duct IPMN would look endoscopically in terms of at the ampulla. Here you've got the major papilla with the typical fish mouth papilla exuding mucus. Here we have an example of somebody with IPMN in the setting of pancreas divisum. So you have mucin coming out of the minor papilla. If you kind of look downstream and to your left, you have a little inkling of where the major papilla is. So on EUS, we get a very nice image, again, as I mentioned earlier, of the entire pancreas. And the way we can delineate this from chronic pancreatitis, which is the main issue here, is that the gland itself is completely atrophic. And that's probably what you guys see in the OR. You have a massively obstructed duct full of mucin with very little pancreas around it, as opposed to a chronically scarred, inflamed gland with a dilated duct. And we can see that on EUS. And that's an example up on the left-hand side of just a dilated, ectatic, tortuous pancreatic duct. Here we're going towards the neck and towards the confluence, and now it's becoming a bit bulbous. Same patient. All of a sudden you see some intraductal growth or a solid component. And here you can see pretty nicely that this is a mass, and this is one that I'd be a little concerned about. And so you've got what we call malignant transformation of their IPMN. They have a solid, not a nodule, but it probably started as a nodule, but now has a solid component to their disease. And you can kind of see that in the sense that right here you've got a mass effect. And so right then and there with our linear echoendoscope, we'll pass a 22 or 19 gauge needle, get cells with cytopathology in the room, and make a diagnosis for you. MRCP can be very helpful as well. So, you know, when these guys get referred to us, we're trying to, we'll start with an EUS. If we think this is a side branch IPMN, it can be a little bit difficult to determine whether these cystic lesions in the pancreas truly communicate with the pancreatic duct on EUS. So, in my mind, the gold standard, the perfect map is a MRCP. And here you can see a couple of nice examples of what that looks like. Again, you've got the key here is that the pancreatic duct looks normal in contour. It's not dilated. And you can see that in all three examples. But then off the main pancreatic duct, you have these cysts. Again, we use the Sende criteria here to determine which ones need to be resected. The overwhelming majority of these people are managed conservatively because it's rare that we find one that's 3 centimeters right off the bat, or it's rare that we can attribute one's symptoms to these cysts. So we tend to watch these folks with serial imaging Q6 months to a year, depending on how we risk stratify them. So I think this would be a nice exercise, if you don't mind, Jose. Similar patient that will come to you, a 79-year-old male who on incidental CT imaging is found to have this. Completely asymptomatic, and he is a diabetic, and he's in your clinic now. And the question is, you know, they're in your clinic because they're asking you to cut it out, or they're in my clinic to ask me, what the hell is this, and what do we do about it? But either way, it's our problem. And the issue is, what do you do? Maybe this is a little more straightforward than you know, a less obvious one. But nonetheless, I think it's a good exercise to go through. And Jose, feel free to chime in as we go through this. So, any takers? What do you see? Number one, pancreas. What do you see? Exactly. So you've got a large cystic mass, probably originating in the head of the pancreas, with downstream dilation, massive dilation of the pancreatic duct in the body that sort of then tapers towards the tail. So what would be your differential? Yeah, it's still a little early in the morning, I see. Not for you guys. Your half day's over, I'm sure. Early for medicine people. Come on. Early for me, not you. Okay. Yes, sir. So we've got, this would be concerning for a cystic neoplasm of the pancreas. We go down our algorithm. This is probably not congenital. He's 82 years old. You know, not that we wouldn't have picked it up by now, but it's probably not acquired because we've asked him if he's ever had pancreatitis, and he hasn't. So this is either a mucinous cystadenoma, and he doesn't really fit the demographic for that. So we would say likely an IPMN, either main duct or side branch. And we can't really tell from this. If it's a side branch, he certainly fulfills the size criteria. And if it's main duct, we're probably talking about surgery. But this is the kicker. That sounds great and all. But now he's in the clinic and saying, you know, I feel fine. And when I went to the surgeon, he said he's going to have to take out the entire pancreas, which is why they usually come back to me, because you guys scare the hell out of them. And he says, I don't want to be a brittle diabetic. And I just bought my RV, and I'm traveling the country, and I don't want to do something that changes my lifestyle. And unfortunately, this is the common scenario. They're 75 to 80 years old. They're in pretty good health, otherwise they wouldn't be seeing us. But we're talking about a big endeavor and a life-changing situation for them. So my issue with this is, number one, all right, how confident are we with making the diagnosis? So I think collecting fluid is reasonable here. determining this is mucinous, and making sure this isn't malignant. I agree. So, that's what we would do. We would check this for mucin. You know what, I'm going to pause this for a second because this... we will check it for lipase. We will do cytology. In our institution, we'll actually send tumor markers. So we'll look for KRAS mutations, GNAS mutations, loss of heterozygosity, because these will help us prognosticate the lesion. And we can talk about that. We have here at UT, we're the PI of a 6-center, multi-center trial looking at patients like this who don't want surgery. And we want to look at the DNAs of their fluid. But let's say we've got a non-malignant process and we've still got a difficult decision to make. Do we resect this? Because we, again, know that somewhere between 50 to 60% of these people, if you have main duct disease, have cancer at the time of the resection. So you can make an argument based on what you saw that there's a 50% chance that he already is harboring cancer. Even though we're not doing a very good, even though we have limitations with our fluid analysis. Yes, if I were to show you the EUS, he had major macrocystic features with septations, and you could almost make an argument, you can see that on the CT scan. Let me go back one. I think you can, you can say that that's a septation, this is a septation, these are septations here. So you think this is a macrocystic lesion. This is probably a main duct IPMN. But the two questions that come up in clinic are, will I get a Whipple for this, or will I get a total pancreatectomy? Because your prognosis is completely dependent on that. And you guys will usually come to me and say, well, Deep, how can we better pre-op these guys so we can have a more precise conversation with them in clinic? To say, because it will certainly make a difference to the patient if we can tell them that you'll most likely get a Whipple. And I understand we keep cutting until our margins are negative, but I agree completely with Jose is that you will see dysplasia on the margins, and sometimes the pathologists will do us a little bit of disservice in this setting. And really, you need to understand the disease. Versus, are you going to keep chopping and have true malignancy that you have to take out the entire gland for?
Doesn't depend on the histology. If it's a low grade, you stop. If it's a high grade, you continue.
That's correct. But we've been in a couple of settings where with the frozen sections, they're not able to tell us, or they tell us one, and on the permanent, it's another story. We get this in tumor board all the time. So in a sense, I almost feel like, and I'm not in the OR with you, but I'd love to be there, but you almost make that decision yourself without the cytopathologist in the room, based on your imaging, based on what I tell you at EUS, and really more importantly, you guys, as you've seen this slide a few times, this is where I like to use pancreatoscopy. Because here we can really give you a roadmap of the duct. Here again you have your classic fish mouth projection. We place a guide wire, we inject contrast. You see the pancreatogram on the left-hand side, tortuous, massively dilated all the way out. Problem is you don't know the extent of disease. Is the duct dilated because of obstruction, or is the duct dilated because there's tumor and disease all the way at the end? No way of telling based on fluoroscopic imaging or based on MR. You just can't tell. So what we do is we pass a scope in the pancreatic duct and we advance it all the way to the tail of the gland. And similar to what we do in our ulcerative colitis patients is we just sample and we biopsy the entire duct. Tail, body, genu, head. We map it out fluoroscopically. We tell you exactly where each set of biopsies are being taken. We then go to our pathologist and say, okay, sample number 1, 2, 3, 4, 5, 6, what are you looking at? And we can kind of chart out the duct for you. And here you can see your classic fish mouth projections, or your fish egg projections in the duct that are pathognomonic for non-dysplastic IPMN. So this is actually a good prognostic feature, as opposed to an ulcerated mass that you can see in the duct and you can get biopsies. So our cytopathologists love this kind of sampling. They like this sampling much better than our fine needle aspiration because we're only giving them cells. And we're usually just giving them mucus as opposed to tissue in the duct. So what we've started doing here at UT is that if you have somebody with main duct disease And we've got this clinical quandary. I mean, if they want to go to the OR, by all means, that is still the standard of care. But if they're on the fence and we don't know, then we'll offer them a pancreatoscopy, map out their duct, have another conversation, and sort of risk stratify these folks, and then either go to the OR or offer them close surveillance. I'll bring these guys back every 6 months to a year, and when they degenerate or they transform into malignancy, we're right there. And that 6-month interval seems to be about right, because again, we're dealing with a pretty slow-growing lesion. And that's been our approach in the GI medicine clinic, which is being adopted. Thank you.
Thanks, Cindy. So, the last lady we did was a 75-year-old sheep farmer, and her CAT scan looked just like that. And she's, to be able to tell her with this sort of diagnostic sophistication is something that not a lot of people have in the state. So there's Sunday criteria that you guys heard about from Japan, and then I tell you that there will soon be some Sundeep criteria from San Antonio one day. And then there's the Almeda criteria, you just operate on everybody. He hates that. Last thing is pseudopapillary tumor. I'll spend 1 minute on there. Usually a young female. This is a trauma patient that got pan scanned on her way in. I forgot to take out her name, I'm sorry, but what do you do with these? These are fun tumors because they have a long 5-year survival. They do great. These are actually fun to operate with. They're pseudopapillary tumors. They're variegated. This is what it looks like. Down here, there's necrotic. There's a nice rind around it. There's a nice rim. And, the cool thing about these things is they get really big and they get really ugly, and it scares a lot of people. Like this one, I think Dr. Half and Dr. Washburn did this one. This is sitting on the hepatic artery, pushing down the portal vein. This was a recurrence at a margin from an old surgery. So sometimes these guys need to come back for surgeries. The interesting thing about this is not to oversimplify it, but they can peel off. And remember this rind here? This rind comes off very nicely. The last case I did in fellowship was a huge one of these on a Jehovah's Witness guy. So you can do them. You have to be prepared to graft this piece of artery if you have to, but that's pseudopapillary tumor. And the only reason I mentioned that is because it sort of sums up everything that we talked about. So this is sort of a slide to sum up the management of it. But really, I think the bottom line is, this is what's new, but the bottom line is when you have a serous lesion, you can watch it. Now you start getting mucin, you have to be careful. The difference between a mucin tumor and an IPMN is whether or not it comes off the branch. You can say, yeah, just operate on all main branch IPMNs, but what if it's a branch IPMN? What if it's an elderly patient? Well, then you got the sophistication of the things that Sandeep talked about to deal with. That really helps guide your therapy for these patients. And the last thing I'll leave you with is sort of what's new. And I show this slide to our radiation oncologists all the time, and they don't like when I show this to them. But you can't really read it. I tried to put his abstract on here. So Johns Hopkins and Stanford and Sloan Kettering, they've combined their forces to do high-dose radiation. So with the signs you see around town for CyberKnife, SBRT, I think that this should be in your bag, in our bag of tricks to treat the patients that can't go to surgery. And it's just high-dose radiation combined with gemcitabine. It scares a lot of radiation oncologists because of the area that this is in, but it works. And you can't see this very much, but I just wanted you to know about it. They're adding more and more patients. They've been doing this for 3 or 4 or 5 years. It's radiation that we already know about, and it's something that I think can be in your tool bag for some patients that can't go. So maybe for Gloria, if she transforms into something malignant and she's cirrhotic, maybe that's something that can be done. But overall, thank you guys for having us. Thanks to Sandeep for coming to be with us. I wanted you guys to meet him, know who he is. I tell the residents all the time, well, just call Sandeep. He'll get the patient in, and he always does. So he's a big asset to our program. He does a lot of things that no one else really does in the state of Texas. So thank you guys for having us. Thanks, man. Let's see if you have any questions.
Can you always make the diagnosis of the pseudopapillary preoperatively?
You can biopsy it, and then it has radiographic appearances that the radiation.
That we know we're doing.
Yeah.
One of your first slides had the syndrome blocking it right now. Von Hippel-Lindau. What about, we didn't really talk about that, the risk of cancer in those patients?
Yeah, yeah. So that's a great question. We have a young man in clinic currently with von Hippel-Lindau, and what you really worry about them is that they get islet cell tumors of the pancreas. They can get serous cystadenomas as well, but the ones you really worry about are the cystic islet cells, also in the setting of renal cell carcinoma. This is just an unfortunate guy. But they also tend to be fairly indolent. So we can, the thing about islet cell tumors, as you guys have probably seen, is that they're tough to pick up because they, on CT scan, can be kind of homogeneous. On EUS, they're isoechoic. So these can be tough lesions to pick up. If they're not metabolically active, they don't come up on your functional scans or your Octria scans. I had a couple of images where we can see these pretty nicely on EUS. They're distinct, they're round, they're well demarcated, and we can pick them up closely. But to answer your question, Ken.
We've seen a couple, and instead of being a nice capsule, you find a thickened area that happens to be the nidus of the cancer.
Yeah.
A lot of times.
Yeah.
Any questions?
Yes.
Dr. Peterson.
Thank you. That's great talk. Appreciate it. Just one question. Procedurally, when you do the pancreatic ductoscopy,
Yes.
is there a change in incidence of pancreatitis post-procedure?
Yeah. That's a great question. You would think so. As endoscopists, the pancreas has always been the black box. We let you guys deal with the pancreas. We don't. The problem is we love it here at UT. If you think about it, this is a chronically obstructed duct. So what we've seen in our chronic pancreatitis and our main duct IPMNs is that you could drive a truck over their pancreas. Hell, I could let Jose operate on one, and they'd be fine. So what we do compared to what you guys do is pretty. But no, so we published a paper on this a couple of years ago, and we found that the incidence of pancreatitis post-DRP or pancreatoscopy is no higher than the average population, and in fact. I think our overall morbidity was about 3% in our first 100 patients. So it's really well tolerated. In fact, we inject, saline. We have to expand the duct. We're in the duct with a pretty big scope, and they tolerate it real nicely.
You guys have come a long way from when you first started doing
Yeah.
here.
Yeah, even just 6 years
We
ago.
had to convince you if you're going to do procedures that you had to look at complications like surgeons.
Yeah.
And originally, it wasn't a complication. It was only a complication if it happened while the tube was down.
That's right. You'd be proud of us, Ken. We even have our own M&M now, so.
7 at night, or
You guys would laugh at it, but we do have an M&M.
God does a lot of bad things.
Speaking
Dr.
of,
Stewart.
That was a great talk.
Thank you.
Yeah, super talk. So main duct IPMNs, to me, I don't really understand
Yeah.
I don't understand observing them, with the exception of, to me, risk stratification should be, can the patient tolerate the operation or not?
Right.
That would
Right.
be, I understand watching those patients.
Yeah.
But if I'm going to put it in a GI context. If I said I had if you scoped me and I had a 4 centimeter adenomatous polyp that you biopsied that had high-grade dysplasia,
Yeah.
I think everyone would say that needs to come out.
Yeah.
So
Absolutely.
So to me, it's not the risk of cancer, 20%, 50%, because actually, if you were operating, I'm putting myself in the patient's shoes. If I had a main duct IPMN and I had this discussion with both you two, and you're talking about what could be cancer, may not be cancer, 50%, 20%. To me, if you operated on me and I had a large IPMN main duct and it didn't have cancer, I would be very happy, because in essence, that's the one time where it's likely to be curative. I give Jose a hard time all the time that rarely, once it's cancer, is the operation actually really curative. It's mostly palliative. So to me, it's the opportunity to actually treat a pancreatic cancer in a pre-malignant position.
But palliation is good.
palliation is good, cure is better.
Yeah, no, I agree with you completely, Ronnie. You know, the issue is, you know, if they're 60, 65, I agree with you 100%. And in fact, my 75, that I kind of do my thumb test and say, I think my guys would operate on you, I advocate surgery, 100%. But the issue is, it's hard to talk these patients into it. And we really still don't know the natural history of these diseases. My big argument every time we get together is, how do we know about that 50% malignant rate? These are on autopsy studies. These are on, you know, mostly autopsy studies, actually. And so one could make the argument that if you're 75 years old, that you will take this disease to your grave. There's at least a 60% chance, in my mind, you'll take this disease to your grave and die of something else and have a good 10 years. That's a problem. It's more the demographic of when they present to you is what leads us to do what we do. Now, my point being is because most of the time they'll say, Doc, if you're convinced I have high-grade dysplasia or cancer, fine, I'll deal with the risk-benefit ratio of that and move on and go and have surgery. And it's great. I'm in a great position because I look around the room and I can quote him the best morbidity mortality post-Whipple of any guy in the state of Texas. So I'm in a good position here. So I can say, you know what, if you need an operation at any point in time, if I can prove that you have high-grade dysplasia, cancer, if I can do you a justice of surveillance and pick this up fast enough so that you're still a pretty good operative candidate, we still know your 5-year survival is pretty good in that setting. So that's sort of what we do, Ronnie. I mean, they show up, they have main duct IPMN, they're a good surgical candidate. By all means, they're in one of your offices talking about a Whipple or a total pancreatectomy. Problem is, after that conversation, they're coming back and saying, what are my options? I don't want surgery. What can we do? Then I can say, well,
Problem
wait.
is a lot of them are asymptomatic.
That's the issue.
It's been found accidentally. They're octogenarians, and whether you're going to subject them to a Whipple or more extensive procedure.
Right. You know, if they're symptomatic, they'll more likely go under the knife, you know, and they do well post-op. A couple of symptomatic folks will even treat endoscopically occasionally because they're so adverse, or they're not surgical candidates, and we can clean out their mucus and do balloon sweeps, clear out their gland, and give them a good 6 months of eating well, getting their weight back up, a fair quality of life, and they get their surveillance 6 months.
So you're saying that if we have more complications, then you'll send them sooner before they get older. So we should have more complications so you can send them sooner.
No. If you had a higher morbidity, it would help my study of surveillance. Is what I just pour more people in my surveillance pattern. Is what I do.
All right. Thank you. Thank you guys very much.
All right.